Hello, everybody. Thank you so much for coming today. We hope you learn a lot, and we thank you for coming. My name is Melissa Barrett. I am the surgery manager here at Welia Hospital. I wanted to introduce Dr. Holien, who is an orthopedic surgeon. He is a Minnesota native, does work for, or has been coming here for 22 years, but his primary location is in St. Cloud Orthopedic, where they live now. He did his schooling at University of Minnesota, did his residency at Johns Hopkins University, is married to Kelsey, who is also a doctor. She's a family practice doctor, and they have 5 children, ages 11 to 23. Fun fact is he's an amateur actor. You can find him at Paramount in St. Cloud. So thank you for coming, and take it away, Chad.
Well, good morning, or afternoon now. Actually, it's just afternoon. All right. This is actually just the acting job. I'm not really a surgeon. Recognize a few faces here, so welcome to everybody. So we're going to run through stuff here fairly quickly, and a lot of it so we can kind of get this stuff. And I know people want to see kind of some of the cool stuff, like what's the robot do, what's that all about with it. So we'll get to that. But know that as we're going, if you have questions that come up as we're going, please feel free to interrupt, say, excuse me, raise a hand. I'm happy to answer the questions as we go, because this is for you guys to get what you guys want out of it. So can we get to just click on? Okay. So I put down my knee. My knee or hip is bad. We can kind of look at both sides. And can you make it like I'm 20 years old again? First thing I'm going to say is no. Okay. Doesn't matter what they say in all the commercials on TV with everything. I can't make your knee look like it's 20 years old. So the whole goal of everything is how can we treat it? Biggest thing is the whole goal with anything we do from an arthritis standpoint is, number one, it's a progressive process. Once it's there, it's there. We can't reverse it. We can't make it go away, right? So the whole goal of everything is keep your good days as good as they can be and keep your bad days to a minimum. And so we'll kind of go over all the preventative things, some of the non-operative things, and of course, some of the surgical stuff as well. Anybody got a guess on this one? What percentage of U.S. adults will experience arthritic symptoms in their hip or their knee in their lifetime? It's actually 72%, but still a pretty high number. So I always put basically 36% of people end up in the office kind of with diagnoses. 20 to 30% eventually seek some form of aggressive treatment, something like surgery. Okay. So what is arthritis? It's basically inflammation of the joints and destruction of the cartilage. So the common denominator is losing our cushion, our cartilage, in our joints. That can come from infection, trauma, just wear and tear. Most of it that we see people for is what we call garden variety, good old white coat Arthur, wear and tear arthritis. So it is loss of cartilage, but it is accompanied by changes in the way that the lining is, the tendons, the muscles, everything around that kind of get involved as well. Different types of arthritis: rheumatoid, post-traumatic infectious, gouty arthritis, and then wear and tear, like we kind of talked about. What are some of the factors that put us at risk? We kind of alluded to one: age. As we get older, more people can start to, as we get older, things wear out, right? So our surfaces wear out. So as we get older, there is much more of a chance that you can end up with some arthritic changes. Gender: women have a tendency to have a higher risk of having earlier onset and progression of arthritic changes, especially in hips and knees. One of the other risks is obesity. The more weight we carry, the more weight our joints feel. And just like putting tires on an F-150 versus a Volkswagen Beetle, right? There's more pressure on that F-150. Smoking actually does, as an orthopedic surgeon, I never come in here and talk about the heart, the lungs, all that kind of stuff, the risks of smoking. What I talk about is it does increase the risk of progressing of arthritis. And we actually do talk about it when it comes to replacement surgery. It's a big deal when it comes to replacements. So if people are going to come and sit in my office and talk to me, I'll tell you if anybody's smoking, I would tell you we need to quit smoking around the time of the surgery to have everything heal up as best they can. Occupation, obviously people who are on their feet, working, doing stuff more are at a higher risk than people who are on in office types jobs, that kind of stuff. And then genetics. Some people are just a little bit more predisposed to getting arthritis and wear and tear. Okay, so what do we do to treat it? So it's a progressive process like we talked about. Primary goal, talked about, keep those good days good and the bad days not so bad. So there are three different parts that we can look at it. What can you do as a patient to help it out? What can I do with you to help you? And then as a surgeon, then it comes down to what can I do to you to help it out? One thing patients can do is weight loss. We kind of talked about that. Just the physics of a knee and a hip. The knee feels 2.5 pounds for every pound you carry. So if you do the math, the 10-pound weight loss, and people talk about Fitbits and you know getting 10,000 steps in a day. So if you do 25 pounds per step after a 10-pound weight loss, 10,000 steps a day, that's 250,000 pounds of stress that doesn't go through a knee in one day. You extrapolate that out through a month, a year, a lifetime. You know, when it comes to like lasting of a replacement, for instance, afterwards, a 10-pound weight loss could mean the difference between a knee lasting an extra 2 to 7 years at the end of it, just from a 10-pound weight loss. That's one thing that can be done. Exercise, activity is beneficial. It helps produce the fluids we need, strengthens the supporting structures, the bone, the ligaments, the muscles, the tendons. It just helps overall metabolism and healing issues with it. So people always come in and talk about, well, doctor, my knee hurts, so I can't exercise. What I always tell people is there's always some stuff we can do. It's just depending, you have to change what you used to do. Like, can you go out and run? Probably not. Can you swim? Can you walk in the water? Can you bike on a stationary bike? Those things can be easier. So sometimes it's finding different things to do. Activity modification, as I just talked about, move towards low impact activities. Job changes. We get to the point where I'm seeing patients, a lot more younger patients with earlier arthritis. We have to have that hard conversation sometimes about, you keep doing what you're doing, but we're going to keep paying for it, or we have to find something that's less impactful. And we can help that sometimes. Some of it is we have to accept where we're at. You wake up in the morning and you realize you're not 20 anymore. Sometimes that's the hardest part for any of us to do, right? Who here shook their head the first time when they got out of a chair and they made that noise that Grandpa used to make? Okay. That happened to me, and I threw a couple expletives at myself. But we just have to admit kind of where we're at sometimes. Things we can do with you. Therapy is here. They're going to actually talk about some of the stuff around surgery with it, but they're beneficial even beforehand. Sometimes setting up a strengthening program. What low impact stuff can you do to help out before you have to get to the point to do something aggressive? They have different modalities to help calm things down, because who here has had arthritic pain? Is it always the same? No, it goes up and down, right? Weather changes, activity changes, anything like that. That all changes it. And so sometimes they can help cut down those flares. When it comes to weather changes, I trust my patients more than I trust any weatherman. Okay? If they say it's going to be sunny and you come in and say, I'm not feeling great, I think it's going to rain today, I'm grabbing an umbrella. So there is something to that. Assistive devices, shoe inserts, canes, walkers, wheelchairs. Nobody's getting to that point. Alternative medicines. People look at me and they'll come in and see me in the office and like, oh, I shouldn't tell you, but I went and saw an acupuncturist, or I went and saw a chiropractor. And they're kind of thinking I'm going to scold them. Like, whatever helps. If it works, great. I jokingly tell patients that if somebody comes in and swears to me that if they stand on their left leg and turn in a counterclockwise circle 3 times every time there's a full moon, my knee feels better. Keep doing it until it stops working. Because I'm not going to make you better if that's making you better already. So medicines, different types that we can use, the classics, the over-the-counter, the ibuprofen, the Aleve, the NSAIDs, Tylenol, supplements like glucosamine, chondroitin. When you get supplements, some of the stuff works, some of it doesn't with it. The hard part is I can't prescribe that to you, and it's not regulated. So what's in there, sometimes you don't know. I tell people if you're going to try it, the rule of thumb I have is never buy the most expensive stuff you can find and never buy the cheapest stuff you can find. Number one. And number two, some of those medicines you have to let them give a good try for 3 to 6 months to see if it's going to help. If you go that long and you don't notice any difference, probably not going to help. Then it's up to you whether you want to keep spending money on it or not. But they can help. Then there are pain medications. You can go down the road of kind of actual pain medicines. One's a non-narcotic called tramadol, which is a cousin of narcotics. And then you can get to narcotics. Now, big things with the cannabinoids, the CBDs, and now the THC products that are now becoming more legal. Those, I always tell people, talk to your primary doctor about kind of those types of things, because all those come with another set of stuff that you have to look at. Topical medications, the stuff you can find in the aisles, the Bengay. There's one that's there called Voltaren, or it's diclofenac gel. The interesting thing about that one is it's the only one that's over the counter that's actually an anti-inflammatory medicine. So it's a cousin of ibuprofen and Aleve, that kind of stuff that you can use topically. When people ask me what's going to work, what isn't, or how successful are they, I always tell each individual is 50-50 for you. For you, I can give you every number in the world, but it's either going to help you or it's not. And sometimes you don't know until you try it. Yeah.
So that Voltaren or that diclofenac, you're good with using that?
Yep, that's okay to use. Yeah, I mean, don't like use an entire tube every day, but yeah, I think it's very reasonable to use for a lot of people. And the nice thing is that it is local in the area, so sometimes when people can't take ibuprofen and Aleve because of stomach issues or kidney issues with it, so little of it gets kind of into the bloodstream that using it topically, if it's helping it can be effective, but not have to worry about the other issues that you can get with it. One of the things we can do as physicians, and that's primary doctors. I know some of you know Dr. Mullen, who's a sports medicine, musculoskeletal doctor who's non-operative, and then us as surgeons as well. One of the jobs that we have is to help kind of figure this out for you. What's going to be the best cocktail for you? What's the, is a medicine and an exercise program, physical therapy, injection, surgery, whatever. That's our job to help you kind of coordinate it, because there's a lot of stuff out there, and if anybody looks at Dr. Google, and talks to Dr. Google, there are a lot of things that they're going to tell you is the best thing to do out there with it. It gets more confusing than any time. So we can always help with that. So what can we do to you that can help out? One of the big things that we talk about next is injections, which is directly, the pro of an injection is it's going directly into the joint we're dealing with. And you're kind of trying to treat that one spot rather than kind of systemically. First one we talk about is steroid or cortisone shots. Fun fact is cortisone is what everybody calls it. We haven't used cortisone in about 50 years. But everybody calls it cortisone shot. It's kind of like everything is a Kleenex. Puffs hates it, but everything's a Kleenex, right? So what the steroid is meant to do in the injection is essentially it cuts down the inflammation. It's kind of like taking a high-powered Advil and putting it right into the joints, trying to calm things down in there. That's the way that works with it. The next injection is hyaluronic acid injection, or who's heard of rooster comb injections. The reason they call it a rooster comb injection is when they figured out hyaluronic acid is something they could inject, they found a high concentration of it in rooster combs. Whoever decided to go look in rooster combs, I don't know, but that's where it came from with that. So, but now it's all synthetic. It's not made from rooster combs. So if everybody gets the injections, you're not going to wake up in the morning and crow at the sun on Friday. Okay? But basically the way it works essentially is we lose components of our normal joint fluid when we get arthritis. Things change. So it becomes more watery, less viscous. One of the things that it loses is this hyaluronic acid. By injecting it back in, we're not changing the oil in the car. It doesn't stick around forever. But what it does for some people is it changes, it stimulates their body to make more normal joint fluid, which then in turn makes them feel better. So it's not better or worse than steroid, it just works differently, and we just can't predict which is going to work. Then the next things we look at are what we call the biologic injections. This is where you hear all the commercials on the radio and stuff like that for using your body's own healing components to fix arthritis. The first one we talk about is called PRP, which is where you take your own blood and you spin it down, and the layer that has the platelets in it has some growth factors and some stimulating factors in it that you can inject back in. And for some people, it can help stabilize the way that the cartilage is deteriorating. Similar type of thing. We'll get to that. We're talking about stem cells. Stem cells is a similar type of a theory, just more concentrated cells to kind of do this. The big thing that gets talked about with that I will kind of try to tell everybody right away is when you see the advertising on things like that, is it makes it sound like it's going to reverse the arthritis. It does not reverse the arthritis, but for some people it may stabilize how quickly things are wearing out in there. So that's where those can work. The big thing with PRP and stem cell injections is, I just tell people right up front, insurance does not cover that. For the most part, they will not cover it, and it can get expensive. And so I tell people it's something you can try, but understanding that it could cost money, and especially like stem cells are in the thousands of dollars with it. If they work, great, but just understanding insurance just doesn't cover it at this point. Prolotherapy is something where you can go in and you can do kind of needle injections of some either kind of salt water or even some numbing medicine. It is kind of poking the tissues around to try to stimulate them to kind of irritate them to get angry and start to reheal. Essentially, is the way that it works. So it's kind of piss it off to get it better. That's the best way to think of that. Stem cells we talked about. Arthroscopy. So simple surgeries where we're not talking about a replacement is to go in and clean things up. We used to do that for surgery 20 years ago, or for arthritis 20 years ago, but studies have actually shown that going in there purely because it's arthritic and just trying to, as I call it, mow the lawn and trim the hedges, just to clean things up in there, wasn't any more long-term effective than doing an injection. So insurance companies actually have basically said, we can't do that anymore for arthritis. Now, it doesn't mean you can't get other things like, has anybody heard of a meniscus? So it's a cartilage ring that's in the knee. And sometimes as our knee wears out, she can get what's called the degenerative tear of the meniscus because it just wears it out and rubs it and tears it. And if that starts to give people symptoms, it's mechanically locking or catching in there, then we can go in there and clean that up. And you can also clean things at the other time. Those can be a little bit more effective. So scopes still have a role to play in arthritis, but it's kind of one where we have to really determine if it's going to be helpful or not. It's kind of what you're talking about with that. Realignment surgeries, I'll briefly touch on that. Sometimes we can do something which is called stealing from Peter to pay Paul. So we usually wear out on one side versus the other a little bit more. And so sometimes what you can do is you can realign the bone to take the pressure off of one side and put it back to the other side of it. Usually where we look at that at this point in time is in a really young patient who has a focal area on one side. You want to buy him more time before you're talking about injury replacement surgeries with it. But it's still something that's just that we consider. Biologic reconstruction, if people have a small area, again, younger patients, sometimes we can go in and transfer cartilage from one area to another, put it in there to kind of stabilize it again. These are in when you say, okay, we really don't want to target replacement surgery at this point with it. We want to kind of buy some time before we need that. But those are things that can be done. Cartilage transplant, same thing. Yeah, those are just kind of the. Then the bulk of what we kind of talk about is replacement surgery. That's what all this stuff is all about here. First thing I talk about with the replacement with everybody is, I will never ever tell anybody when they come into my office that they need to do a replacement, that it's time to do it. They tell me. Because you're the ones who are living with it every day, you're the ones who are going through it. My job is to say, is it a reasonable thing to do? And then, as I jokingly say, then be the trained monkey and do the surgery. But once we get to that point, there are different ways we can do it. And that's where all this stuff comes in. Traditional was to do what's called a standard replacement. And that's where we would use a mechanical alignment. You get one rod that says, we're going to put this in at this angle. This is where we're making the cuts. And these are here. So there's not really a lot of flexibility to that. It's either you do this or you don't. Obviously, that's kind of averaging and saying one size fits everyone, right? Then the next thing we did, which is something called computer-assisted orthopedic surgery, or I always like that the acronym was CHAOS. Needed a better acronym for that. But so the next iteration with it was to say, hey, not everybody's the same. Can we do something that says we can look at this a little bit differently and try to say, instead of putting this 3 degrees, 4 degrees, or 8 degrees, that I can put it at 0 to 10 degrees of whatever we need to do on any individual. So we could do that by using computer assistance to align it to see where your knee moves and what it looks like. And that was kind of the first iteration of robotics. And I actually started doing computer assisted surgery 20 years ago. We did it. We were kind of in the area, and so we were the first ones to start doing the navigation stuff. So we used computer assistance for about 20 years. Then robotics was the next step, and I kind of call robotics the 2.0 version of what we were doing before, the upgrade version. Because we could see the numbers, we could see things moving live, but what we didn't have the ability to do is to say, okay, we're going to keep this exactly where it is when we're doing the surgery. Robotics gave it. Then the other thing that's happened now, and therapy will talk about this a little bit, is we changed a lot of the way we do things before and after surgery to get people up and going right away. 25 years ago, when I was training, and aging myself a little bit here, but we were excited in training when we got to the point where we got people who weren't in the hospital for 7 days and we got them out in 5 days. That was an exciting thing. And then in the next 5 years, we got it down to 4 days, 3 days, and we were all excited. Now we do a lot of these are actually done outpatient. And come in and go home the day of the surgery, or if they're admitted, they're in overnight, or occasionally a couple of days if you have to go somewhere to get stronger. Can't be at home, that kind of a thing. But so part of that is how we're treating people beforehand, but also just the way we kind of get people moving and going right after surgery is a big part of getting better. So we have rapid recovery protocols, change the way we do pain medication, pain management. With all that being said, any patient and people in here who I've operated on can tell you, I always tell everybody after knee replacement surgery, I don't plan on being on anybody's Christmas card list the first week or two after surgery. because we do everything we can to help it out, but it's still going to be sore. It's still going to hurt, but we get you through it. So replacements. There are different types of replacements. One is that we look at partial or total. A partial replacement we can do is if one area of your knee is worn out and the rest of it is good. To be honest, that's probably in my practice about 5 to 10% of people who fit into that category. Because most of the time, by the time they're in seeing us with it, there's enough wear and tear and most of the knee. A lot of this stuff goes with the hip too, except for the partial replacement stuff. I just kind of want to get through. I use the knee as the example here. But the benefit of a partial replacement is they feel more normal because you got more normal knee in there. But the risk is that if the rest of the knee starts to wear out more over time, you can end up having to revise it to a total knee down the road, and sometimes sooner than you expect. Total replacement is kind of the gold standard. It's what we've used for a long time. People always ask, how long do they last? Studies show that at 10 years, 95% are doing well. At 15 years, 85 to 90% are still doing well. And at 20 years, 80% are still doing well. So, good chance that 4 out of 5 times people can get 20 plus years out of them. And who here has heard kind of when we used to tell people 10 years is kind of what you could get out of a replacement? That was related to the plastics that we used in the knees at that time. Now, the types of plastics that we use have much lower wear characteristics and they last a lot longer. So that has not become the limiting factor anymore. The plastics we use when we simulate use 30, 35 years worth of wear. So much different that way. So how do we do the surgery? We kind of talked about that a little bit. Standard, chaos, custom cutting blocks, robotics. This is just what a standard one looks like. We'd use just to make a cut. You put something on there and it measures it off of one thing. And then this was more just a quick screen on computer assistance. So at the time of the surgery, I could go in and measure things right then and there. And then I'm looking live at a computer screen, and when I put like the cutting pieces I would put on there, I could put them in at an exact angle. The thing about those is once I put that on there, I'm still using a saw that can move anywhere. And so it kind of, at that point, I could measure it down to the 10th of a degree, but the freedom that we had would be a 4 degree. Does that make sense? So it was much closer than this, but we could only get this concise. Now with the robotics, which I think is, yeah. So with the robotics, we can get more precise with it, and that's what we'll kind of show here when we're looking at that. So how do we do robotic surgery? First of all, I tell everybody, it is not a robot doing a surgery, okay? I am not sitting in a control room eating a jelly donut while Rosie from the Jetsons walks in and does your surgery. Okay? So it is me using the robotics and using the robotic arm in surgery, not the robot doing surgery. The other thing I always tell everybody is I make all the decisions. The robot doesn't. This is not AI, okay? The minute the robot starts to tell me what to do, I quit. I'm done. It can do it, I'm out of here. But what the robotics allows us to do is we can actually plan your surgery beforehand. So when we do the surgery, we do a CT scan, which is what this kind of shows, and we get this 3-dimensional model on a computer, and then I can virtually do your replacement. Put in what we're going to put in there, put the angles in, and decide what side is going to be best for you. But that's an initial plan. We don't know what it's going to look like until we get in there. We don't know how your ligaments are working, so how tight your rubber bands are. We just guess that beforehand. Once you're under anesthesia, then I can actually check it live and see how those rubber bands look. That's what we call balancing. We'll talk about that here as we do it. But we can do all those adjustments before we make any cuts, before we do anything in there, so we don't have to play around. Who here does carpentry work or does some woodwork type of stuff? So the analogy I use with this is what we can do with this is we can laser print this beforehand and know exactly where that cut's going to be, rather than saying, okay, well, this looks like the right cut, make the cuts here. Well, then something's shorter on one side than the other, or the ground's uneven. So you're shimming one side, you're taking a little bit off, you're putting more on, and you're kind of readjusting and playing around. The nice thing about this is we can do that beforehand. We don't have to do the playing around in there and shimming and recutting. So it means less time in there, less damage to you, essentially. And then we'll go into this actually with the talk itself and exactly how we're doing it. We can show you it a little bit easier. This is just when we don't have that. Post-op, the management, we have definite post-op protocols, and we'll actually have segue into kind of having probably from therapy talk to you a little bit. One of the big things is it really is trying to set it up as much as we can beforehand and kind of working together from all different directions to get things going as quickly as we can afterwards. We know that the best outcomes that people can have after replacement surgery is getting up, getting using it, and getting going right after surgery. It's just been shown in multiple studies that the sooner we get you going, the better off we are. Nursing staff, therapy, very vital in kind of getting everybody through it and even pre-operatively. So again, this is kind of a quick talk. Take-home points. Somehow, or healthcare changes, we all know that Medicare and insurance and everything is making things harder and harder to do in the ways we want to do it, right? They set protocols, they set guidelines on how to do stuff with it. You know, I'll just quickly mention, we used to have the ability to kind of, you went into the hospital, you're an inpatient. If we said, hey, you can't be at home, we're going to send you to a nursing home to get stronger, rehab area to get stronger for a little while before you go home. When we asked this to have patients be able to be outpatient surgeries too, Medicare decided that, well, if you're going to say you want an outpatient, then everybody's determined to be an outpatient by default. Then you have to have a reason why they're going to be inpatient. And then to go to a nursing home, they have to stay to rehab. They have to be in the hospital for 3 midnights to qualify. Well, guess what Medicare says the average length of stay should be for replacement surgery? 1.5 days. So by their definition, if you come in and you're doing okay after the surgery the way they expect it to, you should never qualify to go somewhere to get stronger. So we do have to fight that. We do have to do that stuff. Sometimes that's not our call. So I just tell everybody, we work on it. We do what we can. My job is I'm going to do everything I can to help you as a patient get what you need to with it. But, you know, we all get frustrated. And so the reason I bring it up too is sometimes people come in and say, I'm ready for surgery. They'll also say sometimes we have to try different things like an injection or therapy or things like that. So sometimes we end up having to jump through hoops before we get to that point with it. Basically more math than anything, but we can't change that. So again, one of the take homes, whatever you do treating arthritis with it, the whole goal is to make those good days as good as they can be and keep the bad days. I always tell everybody, I'm a surgeon. I do it because I like to do surgery. But I'll also tell every patient, if there's stuff we can get you better without doing that, or before we do that with it, we'll do that first. Because, you know, my job is just to see if we can get you as good as we can. With that being said, any questions about kind of, this was a quick talk. I didn't go into hips much with it because I didn't want to make it too long with it. A lot of similar things as far as what you can do for it. So for some of the surgical stuff, it's a little bit different. But yeah.
How much, if you know you're going to plan your surgery for a few months out, how soon should we start seeing you to get that CT and all that rolling? Like, how much time should we allow for insurance?
So I always tell people, when you know you kind of want to do something down the road, the sooner the better to come in and do it, because we can always work down the road with it. But what you need before the surgery, so if you came in today, I tell people it's usually at least a month before you could, and that's not looking at, you know, if the surgery schedule's booked up or something, but to get all the okay from insurance, because we have to pre-authorize everything now. So before we can even put it on the schedule, they have to give us the okay to do it. And then the logistics of getting the CT scan sets and pre-op with your primary and that kind of stuff. So, and we actually have, you see the therapist before, which Kelly might talk about prehab. They kind of teach you what you're going to do afterwards and kind of go over stuff beforehand. So just to get all those things in, I just tell people it's about a month.
If you have a cortisone shot in there, how long till you can have surgery?
Good question. We recommend 3 months between from your last steroid shot in that joint until we do a replacement, because it lowers the immune system, your ability to fight infection in that area while that steroid's on board. Steroid takes between 8 and 10 weeks to go away, so we tell people 3 months before we would do a replacement on it.
Age in that?
No. I tell people, you know, the older we get, the more we just have to be cautious about what else can happen around the time of surgery with it, because it is an elective surgery. So I have that discussion, but you know, the two fastest growing, the two fastest growing areas of age groups of people getting replacements are people younger than 55 and older than 80, because we're beating our joints up sooner in our life, and we're living healthier longer. And so there are a lot more people in their 80s who, you know, to be honest, I see a lot of patients that I'm doing surgeries on in their 80s that are healthier than some of my 65-year-old patients that I'm doing surgery on. So.
Does this hospital do this surgery, the robotic surgery?
Yep. This is actually the robot from upstairs.
That was my question.
Yep, we have it on here. Yep.
Is there a limitation on what you can do afterwards? Like I've heard that you can't get on your knees and get a knee replacement.
So I don't say that there is a limit on what you can do as far as, so yeah, I'll address kneeling specifically. It used to be, with the previous prostheses that we had, the replacements, they weren't designed to get great range of motion with it. So if you knelt on them, you're stressing it too much with it. Now, these designs are made to have high range of motion, so you're not stressing the replacement. So you can kneel on them. I tell people you may kneel on your knees. I would tell you that 50% of people tolerate it well, 50% don't like it, because it is plastic and metal kind of underneath your skin and stuff, and so some people it's just not comfortable. But you can. As far as, I don't really restrict people on what they can and can't do. I just recommend trying to watch how much high impact activity you do with it. And this comes down to when I tell all patients with it, we're putting in a mechanical part, right? What happens with mechanical parts? They wear. So I think of it as a set of tires on a car. You take 2 sets of tires and put them on 2 of the same cars, brand new tires. One car you drive 5,000 miles a year, the other you drive 25,000 miles a year. Which tires are going to wear out first? 25. Big thing is the tires are still put on the car to drive it, but you just have to be careful on how you're driving it. Can't sometimes figure out, or you can't change how much you're driving, but you can change how you drive it. You come up to a stoplight, if you squeal the tires off the line every time you leave that stoplight, those tires are going to wear out much more than if you're driving nicely. Jokingly, I'm going to say is also, we live in Minnesota. There's a big difference between driving that car on a freshly paved highway or a Minnesota pothole highway, right? So, but just watching the impact. But otherwise, be back to it. In general, I do tell everybody that, you know, the best way to describe it is only God can give us God-given parts, right? Everything else we put in is an aftermarket. It's like aftermarket parts in cars that work pretty well, but they're never quite the same as factory stuff. So a complete success to me after replacement is if you can do 90% of what you want to do on a daily basis comfortably, that's a complete success. Doesn't mean that you won't get tweaks and twinges that may here and there, because that can happen. There may be 10% of things that you just don't feel comfortable with. If you have specifics like, can I golf? Yes. Can I hunt? Yes. Can I do these things? Yes. I can answer specific questions, but for some people, it's my way of saying it's never going to be perfect, but it should be a lot better than what you have.
Is this the last go to the airport?
Yes.
Standing?
Yep. So I tell people with replacements, just plan to take a little bit extra time going through. Now it's not quite as much anymore with the X-ray screening that they do because they see it right then and there. They may still come by and do a quick blonde, but it's not like they got to patch down and all this stuff. So. Yeah.
How long does that actual hip surgery take?
So the surgery itself, from the time that I start, so making a cut on the skin till we're closed up, less than an hour. You're in there a little longer, getting under anesthesia kind of position and stuff like that. But both surgeries, hip and a knee, are less than an hour.
You put you up fully?
There are different ways you can get put out fully, or you can do a spinal. You're still snoozing through it because nobody really wants to hear what I'm doing. So I usually leave it up to the anesthesia people and you guys, and they just know my preferences. I don't care if you're snoozing through it and under a spinal or fully asleep, as long as you're not trying to help me. Other questions?
Can you do more than one knee at a time? Because I know that I've heard different scenarios. So I'm by myself and I thought I'm supposed to have 2 knees and a hip replacement. It'd be nice if I could go in and get it all done at once because it said probably have to go in a system place for a while or something.
We don't recommend it anymore. We used to, 20 years ago I did them. I probably stopped doing bilateral knees 15 years ago maybe, something like that, right around that.
Because you have all those extra recovery times.
Yeah, so what we do, because the big risk of it is we've known for a long time that when you do them both at the same time, there's a higher risk of infections, higher risk of blood clots, higher risk of bleeding issues. And so with those risks, we don't like to have people in the operating room that long. And plus, it sounds good to have the recovery be at the same time, and I get where you're talking about with it, but it gets harder to do that full recovery with both knees involved at the same time. So what we saw was some of the outcomes weren't as good, and people getting the motion back, getting the strength and functioning back. So what we've done now at this point is we kind of went to a medium with it. You do one, and then you get partially through your recovery, and then do the other one. So you're not waiting until you're fully recovered and taking 4 months on this one, and then 4 months on this one, and then 4 months on the other one. Maybe you're
Until you feel like you spend the rest of your whole life healing from surgery.
right. So so maybe we do one, you do one, and then you do one 6 or 8 weeks later. You're only halfway through recovery, but it's strong enough to be your good leg at that point. So it shortens down the overall recovery period, like we talked about with it, but definitely decreases those risks of having complications that could be kind of life
So you
changing.
recommend that the hip to stabilize first, because I was told like 12 years ago I was supposed to do knee replacement. And then my hip went. And
I usually tell people, do whichever one's bothering you the most at that time frame with it. When it comes to a hip versus a knee, people who talk to me in the office, that I describe it as, there's a difference between the two. Hips want to work after surgery, you just have to help them. So the recovery isn't as aggressive sometimes. You have to help it along, but you're not having to push everything as hard. Knees get pissed off at surgery, and you have to make them work after. So that's the difference between probably vouch for that. And so I jokingly always tell people which one should I do first, my hip or my knee? And I say, well, do you want to come back for the second one? Then I'll say do the hip first because it's a little bit easier to get through the recovery. But in general, I tell people, to be honest, if you have 3 involved, I'd say pick which one bugs you the most, start there. Other questions?
oh yeah, hold on. No, I have a pacemaker. Is there any restrictions for people who have pacemakers?
I mean, as long as, cardiology clears it enough, to say that you're safe enough to go through the surgery.
Right.
But no, as far as putting in the replacements. I'm going to quickly have Kelly step in. Kelly's one of our therapists here. So she can kind of talk a little bit of the protocol stuff and what we do before and after the surgery, kind of we alluded to, that's a big part of this. Then what we'll do from there is we'll go through the replacement itself, and then you guys can ask questions as we go. So I'm still going to be here for questions as we go, but you guys even got some lunch, but you want to see the cool stuff, the robotics, you want to listen to me talk. So with that, Kelly.
Yep, so my name is Kelly. I'm a physical therapist here at Laura, and an orthopedic physical specialist. So before your hip or knee surgery, you'll have what's called a prehab evaluation in our clinic. So at our prehab evaluation, what we're really looking for is how are you moving right now? How do things look right now? How are you functioning right now? Just so we kind of know what to expect for maybe after surgery to best prepare you for that. Since we've shifted to more of a same-day surgery, we have to do a lot more prep work beforehand just to make sure you're as successful as possible. So that prehab physical therapy visit is part of that. So we'll kind of look at how are you moving now? Do you need any assistive devices now? What kind of equipment do you already have? Like a walker or a cane or tower chair? Like what do you have right now versus what will you need after surgery when you go home? Most of the patients that we see do go home the same day or the next morning, and then we see you the following day right away. So you need to be like, get into your home safely and then get to therapy the next day and be ready to go. So it's a lot of just prep work. A lot of that is discussing things with you as far as your home setup. And it's how can we make you move easier so you're as successful as possible. With that, you get a book that has a lot of the clinical stuff on it, but also some good rehab tools in there as well. They have a set of exercises that you can do before surgery to kind of prepare your knee or your hip for surgery beforehand. What we see is patients that partake in prehab, kind of some rehab before their surgery, tend to have better outcomes after surgery. They just seem to recover a little bit easier, especially in those early phases. I'll go back to muscle memory. When your body already kind of knows what to do and what to expect, it makes it easier to do after your surgery. So we'll give you exercises that kind of help prep for that. And then for after surgery, before you go home, even from like your surgery date, a therapist will see you just to make sure that you are completely safely and you get home safely. On the outpatient side, we tend to see you day 1 or day 2 after surgery, which I think is kind of what you prefer with that, just to make sure that you are up and moving, that your pain is well managed, that you know what to do and feel like you're managing things well. So that first visit just kind of get you in. Some patients are moving better than others. Typically at that 48-hour mark, they're not feeling very good and are not happy to have to come see as an outpatient. But we get you going and kind of use some tips on how to manage your pain to get you through that. And then that next day we get to work. I would say rehab recovery for total knees, we typically see patients in the clinic for 8 to 12 weeks on average. For a hip, it's probably 6 to 8 weeks. But then still doing home exercises at home before that. So that's not at your 100% when you're done with therapy, just so you're done with formal therapy, and we ask you to keep going for a while, just so you don't lose what you've already gained.
And the problem with the hips versus knees, see people more frequently with knees than hips.
Yep.
Sometimes the hips is 6 to 8 weeks, but you're kind of checking in every once in a while.
Yeah, exactly. Yep. Hips doesn't tend to be as intensive or as frequent. Usually 8 to 12 weeks, I would say, is average. When the first 2 to 3 weeks, we see patients 3 times a week, just to make sure they're moving and get their knee going. After that, it's 1 to 2 times, depending on how they're doing. A lot of, yeah. It's not a set protocol. It's based on how you're progressing and how you're doing.
Yeah, people will come in and they get to the point where they're seeing these guys, and 4 weeks in, they're going and moving around. It's like, see you later.
Yeah.
How much I can do for you? These guys are good. They're very good at kind of managing each patient with it, and they're very good resources as we go. The prehab has been very vital in kind of all this goes. The better prepared people are going into the surgery, the better they are coming out. You're much more comfortable. You know what's happening. You're not just walking into this black box of what's going to happen next. You kind of know, okay, they've already told me I'm going to do this. I'm going to have to do this afterwards with it. And yeah, this is going to hurt here. I get it. We're going to do this. We're going to get through this. This is what we're going to use to do that. So we do work together. You know, Kelly's very good about, these guys are very good about, hey, I saw so-and-so, send a message, give me an update with it. Can we change this? We need to get you in to see him. You know, hey, let's try this. Let's do this. You know, we're talking to each other to make sure everything's good to go. So.
Yeah, like I said, patients that do prehab, it just seems to make that process a lot easier after surgery. So doing those exercises, it matters.
Other question?
Does insurance pay for all that?
I think so. I don't see that side of it.
Usually. It's usually part of when you get to a point where you're saying we're going to do replacement surgery, they kind of put that all together, and if they're okay, they're going to say yes. That data has shown that it's helpful to do these things with it. As a matter of fact, some of them, when I talked about jumping through hoops, sometimes you can come into my office and you've had bad arthritis, you've been going for a long time, and you're going wanting to get a replacement, and the insurance company will come back and say, we have to see these guys for 4 weeks beforehand. Do that. It's beneficial. I'm very good. I will send patients to these guys if there's motion issues beforehand. I may say, we need to do some therapy before we do the surgery to get you better set up to have a good outcome. When it's jumping through the hoops, then it's sometimes, by the time people have sat in my office, I haven't had too many patients who we've said, they've told us we had to send them to therapy, they go to therapy, they do other stuff, that they're not sitting back in my office saying, okay, when are we scheduling the replacement? But some of it is just what we have to do. But there is definite benefit. Definitely the prehab stuff is very good to help. It does set people up beforehand. And there are some times where I'll say, we need to see therapy for a while, a month or 2 or 3 before we're going to do a replacement, because we've got to get you, instead of starting at square -3, to square 0 at the time of the surgery. All right, well, thank you, Kelly. So now we'll kind of do a quick run through of what happens. So we'll use a knee again. We do similar stuff with a hip replacement. Obviously, it's different because it's a hip, not a knee, but it's easier to kind of show the knee power.
And unfortunately, these monitors can't be kicked over to the screen. So if you want, it'll be a little bit more impactful if you want to move over here. I can adjust this a little bit. This occasion.
So I'll just repeat that. I kind of sit towards me.
Done already.
Just do this and move that way a little bit so you guys can see it. All right. So what happens is we do that CT scan that we talked about, and then this model goes to, first thing it does, it gets put together, and then it gets sent down to the company. They kind of do an initial modeling of it. Then I get that back, and we get their initial modeling, and then I play around with it and say, yeah, I don't like that. That's not, no, what do you do? And then fix it. Right? So we get a model, and so we can have it where it's a 3-dimensional model like this. So this would be somebody's knee. Then we decide what size of, so the first thing we look at is we have all different sizes of these people. And so I can decide if I bring this one down, okay, now if I try to put this size in there, it's going to be taking way too much over here. So then I can put it back to the correct size. And then I can play around with the angles that I have to take the bone away. I can take the implant off, so what the cuts are going to look like. I can manipulate everything around. So basically, I can play with this all before and get everything kind of set with it. Then once we get to surgery, we have to, so that's what it kind of thinks is going to happen. Then once we get into surgery, once you're under anesthesia, I put pins into your, got some poke holes and put some pins down into the bone, and then we attach these trackers. So essentially, these things right here is what tells the computer where your leg is. And I have to use a probe already. Okay. Okay, so that's registered already. So then kind of turn that just a little bit. So then all those points in there, I have to map in to tell the computer where your leg is essentially. It's all in.
Yeah, it's all in.
Okay, so I put all those little points that are all in there with that, map those all in, and then all of those have to be within half a millimeter on average of what the computer thinks it should be. So basically, I can't be off by more than a half a millimeter on anything. If it is, I can't go forward and tell and match the big white spots. Those are moves that we actually put the probe on and have to. It's where it verifies that's where. So once we have that all in, it gives us the model. Then we have to do the same thing on the tibia side. And then once that's all in, then I can play around with the leg. Remember how I said I can move your leg around and check your rubber bands? So the ligaments on the inside and the outside part of the part that we really want to worry about. See, I can do that. Hopefully your knees aren't doing that, because if they are, we're talking about a much bigger surgery. But basically we want this side and this side to be the same. So what we can do with this is I can then see how this is, so we can bring it into extension and we can see where it's at. Now,
I captured some for you already.
okay.
Yeah.
So what do we do?
1.5. Okay.
So, but basically we can see how lax they are on the outside part and the inside part. We can do those there, and then we also do it at 90 degrees, and we do the same thing. See how lax it is on one side versus the other side. So in with the model, we kind of put that in there. So then he went to, so once we have that, we can adjust things. So right now, we want these numbers and these numbers to be even with one another. So then we can make adjustments on where we're going to put stuff. So why don't we bring the finger down and put and now hit it F2 on the finger. Or actually, we there we go. And you got to rotate it. Actually, take it. There, so we can see, so you see how we kind of even things out. I was using this to see how much more we're taking away, where we're putting this stuff, where we're angling everything. So without the robotics with that, what that would have been is me putting that piece in there, making the first cuts. And then I would have been in there going, this is too loose on this side, this is too tight on this side. So I got to take more bone weight here. I have to release this ligament. I have to do stuff to get these. At the end, we need it to be that they're balancing the same way. So you can see that took me, what, a minute to do that adjustment. So once we have that all set, we know this is kind of where it's going to be. So then I bring in, the next part is to bring in the robotics. So this is Mako, this is the robot. You don't have a cool name for it. Mako robot. But basically, if I'm going to, am I actually cutting it?
We can check it in and then I can go solve it off.
Right, is this already checked in?
It is, yeah. It's that black dot, or
Right there.
slide around the grip through there. This.
We're gonna cheat, we're gonna re-register. This is the.
This is a sawbone, and so there's some bumps on it that make it inaccurate. And these are safety measures built into the system to ensure that within a sub-millimeter, we know where you are and where the cutting system is.
So then what happens with this is now.
Get it jumped ahead of me.
This one there.
Keep thinking we're done. One last time here, I apologize. So the femur.
This is trying to make things work, but it's not really in this really there. So then what we do is, so we're making the first cut, the arm. So remember I talked about the free blade kind of, I can move it wherever I can do with a free hand. What this does is I bring it in. So what this does is it puts it at the exact angle. So then I would. So I can take it off just like that with it, so I can watch down there, watch this, make sure I'm taking the same arm going off there. Then go to the.
Doc, are you a lefty?
What's that?
Are you a lefty?
I'm actually in surgery. I'm ambidextrous. I learned.
You charge double for that?
No. No, the best piece of advice I actually got was when I was in training as my intern year, my surgery, and then actually my first year of orthopedics. The doctors told me right away, or this was like, learn to use both hands right off the bat. Because right now you're going to suck at surgery both ways. So you might as well learn it both ways. So, yeah, so we're like in surgery, I can do this and then flip over to the other side so with both hands. So, yeah.
If this were real life, we would have kept the saw attachment off, but we didn't want to blow debris all over everybody in here, so we pulled it off.
Yeah, we don't magically like blow your tissues away. And then
We could bring it to trialing too.
okay, let's just do that. So then we actually switch over and on the knee, we switch over to a different blade, different angle, we do the rest of the cuts. Different cuts. But basically that sets everything up. So now everything's been cut, then we can put in replacement. Put it in here, but so this is what the replacement looks like. So this is the femur and those cuts that we were looking at making angles on there. It's a rounded end, but we want to have it fit on there. If you put a rounded piece on there, then it can do this, right? So we make the cuts at different angles to fit in there. So that's what those cuts we're mimicking, where we're going to put those on that side. That's what goes on this side. Typically, we make a flat cut across there, and then we have a fin that we cut down into the bone. That's what goes down here. Then the piece in between is a plastic piece that sits. So then this, we have different size thicknesses of plastic that we put in there. We actually, on this, I maintain it to go with the thinnest that I can, and usually we stay within a millimeter. Before, when we talked about having a shim cut and all that stuff, we make these extra cuts. What we always had to do is, well, let's take more bone off here to make this better. You take more and more off. Then you have to put a thicker plastic piece in there to make up for it. So, so you're kind of changing the way the anatomy was, but making up for it by putting extra plastic. So you don't have to use much. I'm mad when I have to go a millimeter off of where I normally used to. It's like a little bit looser than it looks. So then that's the way these work. So that's what goes on there. So that's your new knee. Then on the underside of the kneecap, we shave off the underside of the kneecap, the cartilage part, and put a plastic button on there. That's what that rides on here. So plastic rides on metal, metal rides on plastic. Metal doesn't ride on metal. So people talk about, don't you take my kneecap out? We don't take your kneecap out. We resurface, put a new surface on it. You don't want to take your kneecap out. You need your kneecap. It's there for a reason. So we don't take it out. But it is resurfaced. And that's really the surgery. And like I said, the robot itself is a tool that we use when we're in there with it. It does, like I said, it's a high-tech thing. It says to me, hey, dummy, I'm only going to let you do what you said you wanted to do. So that's all it is. You know, it keeps this trained monkey doing what he's supposed to do.
So what is that doing to your meniscus, your ACL, any tissue?
So the meniscus, we take out. The meniscus no longer is needed at the time of replacement. So the meniscus goes. The ACL actually goes as well. The ACL, the PCL, the posterior cruciate ligament, we try to do. That's when it's on the back side of them. That stays in front. So the main ligaments we're talking when I talk about the ligament balance, so the medial and lateral. As far as the way we do surgery, we try to do is minimally invasive or least invasive to the muscles and tissue. So we make small cuts, slide everything over rather than flipping everything open. If you get a video from years ago where you see everything wide open and the knees this big and open, and we don't do that anymore because the more damage you have to do to the tissue, the harder it is to recover after, the slower the recovery is. So we're able to move things out of the way and not do it as big. Our incisions. The incision I tell everybody for a knee replacement is kind of you feel that little bump right below your knee. It's about a half an inch or an inch above the kneecap. And then for a hip, we can do this. I'll talk about that a little bit. Is I do what's called, my preferred method is called the direct anterior approach, which is going to the front side. Which the reason we like to do that is we can go between muscles to get into the joint, kind of like opening curtains, rather than trying to have to peel muscle down off the bone to get in there. And have to, we don't have to restrict people as much afterwards because you don't have anything as far as muscles to heal and repair. So we don't have to restrict people as much. And that incision is something usually about like this. Right on the front side here. If we have to go through the side, not the worst, not the biggest issue in the world. The biggest reason we have to go on the side is just patient size and body habitus. If we go through the front side, you're laying on your back, and sometimes if there's too much belly, it's just in the way. We just can't get in to do what we need to do. So it's just the physics of getting in there. So then we have to do the side, which guys talk about. It's reasonable to do, just a little bit of a different, not a longer recovery, just something different that we have to recover. Big things get you going right away, get you where you're going, and their team to get you back up. Yeah.
How does that metal attach to the bone?
So there are two ways that can be attached. In a knee replacement, there's bone cement and what we call a press fit or an in-groove. So bone cement is for like a grout, like if you tile a floor. So we put a bond in there and this bone cement hardens right away. So when we leave the operating room, it's as solid as it's going to be. That's the benefit of cementing. The other way is called an end growth, and this kind of has, you can kind of see the backside of this process. You see how it kind of has that different look to that metal. So this is a type of metal that's on that allows bone to grow up onto it and into it. So it interdigitates or gets into the metal itself, and that makes it more solid. The benefit of that is it grows in all those little places. Bone cement is kind of like, just like you said, tiling a floor. You tile a floor, you drop something heavy in the floor, you kick that tile, it's fine, right? But you go back across that tile 6 months later, you kick it, it goes flying. Because at that impact, you started to break down that bond and it eventually all goes. Same thing with the bone cement, it's one bond. So once that starts to loosen, it'll eventually all start to kind of go. Whereas, say you have an ingrowth and it's interdigitated, it's in there, it goes in 10 million little spots. You lose 5 million of them, you're still holding on by 5 million spots. So long term, it can be a little bit better. The disadvantage of that is in patients, as we get older, our bone softens some. And so that soft bone, if it's not growing in, it's not solid right away, that can start to collapse a little bit or it can start to break down and move. So in general, with hips, we pretty much ingrow most of them. It's all people in there with bad osteoporosis or in their 80s, high 80s, 90s and stuff, all cement the femur part in. But other than that, it's all just press fit. In knees, kind of 70 and below, I usually press fit everybody if I can. 75 to 75 and 80 and above, I'll cement. You know those bones top up. In between, I kind of see what the bones like. And then obviously, they're pros and cons sometimes. But I've had osteoporosis a lot. But both of them work the same. It feels the same. Yeah, that's how we get it.
That's what I was going to ask you, because I have osteoporosis, and broken bones, and plates and screws, my leg and my arm, and stuff. So that was my concern about all the bone grinding and all that kind of stuff. It's like, when you have osteoporosis,
Yeah.
what kind of concern is that?
Well, again, with osteoporosis and the concerns, again, it's more the stability of the joint because ultimately we're putting in a mechanical part, a metal part in there. We need support, right? It needs to be supported. And so, people have bad osteoporosis. They're different. These are just one type of design of things. We have all different abilities to have stems that go down there, so it's supported more in the bone than we need to. And we try to invade as little as we can. But we have the ability to do as much as we need to. So like if you came in and saw, we would look at where your x-rays were, what's going on, look at your osteoporosis and talk about, do I think a standard is going to work or do we have other stuff we need to do? The options that I have on there is, I just tell everybody, whenever I go into the operating room, I have plan A, B, C, D, and E in my head. And hopefully only have to do A, but I'm prepared to do all. Yeah.
That metal part that goes over the bone there, how is that kept in? Or is that glued in? Is it screwed in?
This one?
Yep.
So again, because of the shape of it, it fits on there solidly. So if it's an ingrowth, that's all we do is we put it in there. That's just on there.
Well, I've got them in both hip joints and I know, the cup. And I know those are screwed in and glued in.
Yep. So with the hip and the cup, my guess is it may not even be glued in, actually.
Yeah, they are glued in because I've had one taken out 2 or 3 times. They have to chisel it out. I had infection in there.
Different story.
Yeah, but that's why I'm just wondering, how is it put in there?
Yeah, so in a hip, most of the time the cups are what we call press fit, so the ingrowth from the backside. and you put the screw in there to hold it in that position because it's wedged in there so it shouldn't shift or move, which is one of the other things that robotics helps with. With a hip, we only have to prepare that once, so it's an actual nice circle. And when you put it in there, it's nice and tight, so it didn't get kind of wobbly. But I always put a screw in there as belts and suspenders in case early on while it's still growing onto it and into it, if you jammed it and didn't want to shift, the screw stops from doing that. The screw's only usually working for about the first 2 to 4 weeks. But after that, it's not doing anything, it's just there. But yours, with infections and things like that, whole different ballgame.
So I've had them in for 14 years now, though, and they've been wonderful.
Yep, yeah. But so with yours being cemented and the other stuff, yeah, that's what we have to do when you get to kind of those types of situations. I do a lot of that stuff, kind of the redos the second time, third time around stuff too. Yes.
Now with total hip replacement in that, I don't know how it equals to a knee or not, but with your leg, when both of your legs are the same size,
Correct.
and that they do a certain calculation in that, with the computer, how is that gonna work with that calculation?
So you're talking about how do we make your leg lengths?
It's even.
So what we can do with it, in knees, we can't really do much as far as limb lengths. You know, if you're really angled, you know, people are really bow-legged or really knock-kneed, all we're really doing is straightening the leg out because those ligaments are what tell us. So we're not going to change that by more than a couple of millimeters. But you may feel longer because we've taken you out of that angle. You can straighten that leg out. With hips, we can change the length a little bit with it. But what we try to do with hip replacements is at the level of the hip, so kind of between the ball itself and the leg itself right here, we try to make that even with the other side. Now, if you have limb length issues lower down, we're not going to change that because if we tried to fix that at the level of the hip, and then we're kind of spitballing it, if that makes sense. We're trying to fix that because when we do it with your hips, people always come in and say, I'm long or I'm short on that side. It's because you've been favoring that hip and the way you stand and you move. If I tilt my pelvis, is people oftentimes with hip replacements, they come in to see me, they got back issues too. And so if I tilt my pelvis 5 degrees, my leg's an inch shorter. So if I try to plan that into my surgery and make you an inch longer on that side, well then you fix your pelvis, and your pelvis gets better because you're not favoring your hip anymore. Suddenly you're feeling way long on that side. So all we do is I can correct right here. So if you're short on that area of the hip, we can plan that. And the nice thing about robotics and with this on the computer side with it, I can tell at the end of this within a millimeter. Am I level with the other side within a millimeter? And I plan that to kind of be level like that.
How much does, after the hip replacement, they worry about it, what am I trying to say? Like if you have dentures, you have your gums pulled out, your teeth pulled out, you have to wait for the gums to swell and swell.
Yep.
And then it's the same thing with the hip replacement, but how do you calculate that?
Not really the same, actually. Because structurally where it's going to move, it's going to be the same because when the bone and the joint are back together, that's the right position with it. You're not going to swell up a lot where it's going to pull it away or anything like that at the time of surgery. When I'm doing my measurements, you may swell around that area, but the joint isn't going to do this or do this or that. So it's a little bit different than that. The fit is because it's in the bone, it's going to fit the way it needs to. That's not going to swell. Other questions? About anything? Anything that we talked about with it or?
There's still some
I'm sorry.
Go ahead.
that piece of metal, what size fits all.
Nope, we have, that's what I was talking about, we can plan it beforehand. Standardly, we have 8 different sizes of these, and most people are going to fit within that size range with it. If they're really big, you can actually, or really small, you can actually custom make it. It's just, you obviously, that takes longer before you get surgery. So it's not one size fits all. It's many sizes fits most.
Are there still weight restrictions for replacements?
Not weight restrictions for it. As far as well, for doing the
Like
surgery
my
or
sister
for.
had to lose X number of pounds before they would.
So that comes into the risk stratification. You look at people's risk. The more weight you carry, and especially perhaps most of us when we carry weight, it's around here, right? And so what that is the more weight we carry around the area, the higher risk there is of an infection and issues with it after the surgery. Because it just comes down to the more tissue you have, the more area there is for bacteria to hide, right? And infection, as you can attest to, is a big deal when it comes to replacement surgery. I tell everybody, we do everything we can to prevent it, but if you get an infection, you can plan on spending the next 1 to 2 years dealing with it after the surgery. Never to get after the infection, never to get back to where you were truly before you had the infection. So we try to prevent everything beforehand. We use kind of body mass index, BMI, as kind of the stratification. It's not the appropriate thing with it, but the higher the BMI, the higher that risk is. And so sometimes we tell people from the risk stratification standpoint, you're better off losing the weight beforehand to do that. And for me, it's even to just get it down a little bit. You drop one iteration of it, that's less infection risk, less issue. That's the point. The other side of it is that thing we talked about way in the beginning with how much stress your knee feels with every count. The hip feels 3 counts. So again, for longevity, if people are losing weight beforehand, I encourage people to work on weight loss beforehand if they can, because there have been many studies that show people who have started weight loss before doing replacement surgery are 10 times more likely to continue that afterwards and to get that back down than if they're going to do the replacement and then start weight loss. We've all done that, right? It's like, I'm going to lose weight. Just get me through the surgery, and then I'll do it. And then you get through the surgery, and you're actually feeling better, right? Because your hips feel better now. Then say, okay, well, now it's time to work on weight. I just recovered from the surgery. I'll get to that. Famous last words, right? So that's where I encourage people beforehand to work on it. Again, it's not where I'm going to say, you've got to lose X amount before your surgery. If people are asking about they really want to do this for a hip, they really want to do that front side incision, that may be one where I say, you got to lose weight. I can't say exactly how much, but you got to come in because, like I said, it's how you lose the weight, where you lose it. I got to be able to get in there. If physics don't dictate I can do what I need to do, I can't do it. So I want that to happen. Other questions? Yeah.
What are the timelines or recommendations for vaccinations before surgery?
Typically, I like it to be 2 weeks before or after. And it's basically because sometimes we react to the vaccines, right? And if you do it right before your surgery and then you react afterwards and you get fevers, chills, all this stuff, we don't know if you're getting an acute infection of the replacement area or if it's related to the vaccine. So we just try to take that factor out. So I just recommend a couple weeks before or after. Other questions? Yeah.
What was your learning curve?
Mine was not as typical as others because remember I kind of talked about using computer assistants beforehand for many years. So for those of us who did that, 5 cases, literally by ear, because I was already used to thinking that way. For people who are going from kind of 0 to 100, doing the standard to doing this, that's probably, what do they say, 50 cases? Yeah, 50 cases.
What's your success rate? How do you measure it?
So,
Sorry to put you on that spot.
no, that's a good question as far as what you determine as success rate. If you look at complication rates, infections, that kind of stuff with it, I tell everybody, if you add every complication you can get, infection, a blood clot, a fracture, anything that can happen, it's about 5% of the time something can happen. My rates are lower than that, and then the success rates to me is, my goal, like I said, is people can do 90% of what they want to do on a daily basis comfortably. That's a success. And so my definition of success, and the patient's definition of success, I try to align them as much as I can. Part of that is setting the expectations beforehand of what's great. My favorite thing is, I have patients who, we've all known these people that they come in on their 6-month follow-up with it, and they fly in the room. They come and sit down in my office, and they sit down. Hey, how's it going? I can't do this, and I can't do this, and I can't do this, and I can't do that. I'm like, well, wait a second. How are you compared to where you were? Like, 150 times better. Okay, well, let's start there. Okay, and go from there with it. And that's the same patient where it took them 10 minutes to get down the hallway on their walker to get into their room. And, in their first post up afterwards, I'm like, I'm chasing them down the hallway to x-ray. But it's really, I really try to work with patients beforehand to understand the expectations. Like I said from the beginning, I can't make you 20 years old. Any 20 years old. And I can't make you 20, but I can try to get you doing as much as you possibly can. The other promise I make to everybody when it comes to recovery and how they're doing after surgery with it, some of my patients who are here for this is, one promise I'll make you is I won't ever blow smoke up your butt. Okay? If you're doing okay, and if I say you're doing okay, I think you're doing okay. If you're not doing okay, I will tell you right then. And I'm not going to go, hey, you're doing great, and walk out and talk to my assistant well who's sitting over there and go, no, we'll tell you with it. Which is the other thing I tell everybody, regardless if you ever have surgery with it, everybody knows somebody else who's had a replacement surgery, right? And once you have it, everybody's going to have the exact thing that you should be doing in it, what you should be able to do or not do at that point in time. Don't listen to it. Listen to yourself in your recovery, because everybody's going to recover differently. Everybody's going to get to a different point. Everybody's coming into it. We're all unique people in unique situations, right? So, well, you should be able to do this already with it. I could do this at 4 days with it. Number one, they probably weren't. Okay. History is revisionist afterwards with it. What you think you were doing, you get 6 months or a year out from something. What you thought you were doing at 3 days afterwards was probably 3 weeks. Okay. And then, revisionist, I don't know what's wrong with you. Why are you having to go to see the doctor 3 times a week? I flew through mine like a breeze. I can be like, oh yeah? Here are the 5 visits you had, extra visits in my office talking about how you things were going in those first couple of weeks. Now, I'm happy to see you deal with it, but then when they go and say, I flew through it, everything was good. It's kind of like, the joke I like to use is like, if you ever do it again, it's kind of like after you've had a baby, and mom's sitting there at 6 months, it was such a wonderful experience, it's such joy, I love you again. Meanwhile, dad's still sitting there with the scar marks on the arm, and he's seared through his face with the laser beams of ice. If this ever happens again, I'm going to kill you. We forget how things work. So when people are giving you that advice, take it as advice. But whatever you have done, talk with your doctor about it. And you're the ones who are in it, and the therapist or anything like that. Yeah.
How does this procedure work on revision?
So revisions typically, for most, we're not using robotics on the revisions with it at this point with it. We can do it for some simple stuff with it, but it just gets to be too complex. We're working on that. We're moving towards some of that. Yeah. And
As far as the device used.
The implants we put in, we have different things. Like we talked about, there are longer steps, there are different things we can you build up to make up for the bone that's gone that we have to make way to take up for it. So all kinds of systems design, that's where it kind of comes to. Like I said, there, like myself, I do a lot of revision stuff with it. There are several doctors who do a lot of primary replacements, but don't want to touch what they have to do it second time around. Well, again, when you talk about revisions, it's a whole gamut of where people are starting from. So success rates on that are really hard to determine what you determine as a success rate, number one. Number two is what's going on. The other thing I tell everybody about replacements in general and revisions and anything like that with it is, you're not hearing the people who are doing well talking about it. The people who are talking are the people who didn't get good results or aren't doing well. You know, so percentage-wise, it's a lot lower percentage, but it's a lot more vocal. So when you hear that not doing, revisions not doing well, there are a lot of revisions out there that are doing well. Part of it is it's never going to be as perfect as the first time around or at setting those expectations, but failures are a lot less. I've learned long ago that when it comes to replacement surgery, I would say I'm a hero or a goat, and nothing in between. Because if people get what they expect, which is to be walk better, to be more normal, everything like that with it, great. Anything short of that, what'd you do wrong? And so I've learned to kind of help people through that. So if you get a complication, if people get through it without a complication, again, like 95+% of people, you ask them in 6 months, the first thing they usually say is, I wish I would have done it sooner. If it's one of the 4 to 5% that had an issue, you ask them in 6 months, the first thing they'll say is, I wish I never did it. But fortunately, last time I checked, 95% is a lot higher percentage than 5%. I always joke about that's why it's called the practice of medicine. Yeah.
Why would you have a partial knee replacement rather than the whole thing?
Preference, and if it's available. Like I said, if you have one area that's worn out, the rest is good. You can keep more of your knee placed, so it feels more normal, it feels more natural.
If you're 70 years old, isn't it likely the rest is going to get
Probably. I have that conversation with people. That's what we're talking about it. And that sometimes comes down to what kind of a gambler are you? Do you like to play blackjack or are you a bingo player? Bingo, we know we're going to get. That's a total. You know it's going to be good. You're going to win. So if you play bingo long enough, you're going to win, right? And it's going to be there with it, but you're not taking a risk of something bad happening. It's bad happening, but you may not get as big of a win. It has to feel as natural as normal. But and to be honest, at 70, I'm not usually talking a lot about partial replacements. I'll say, if there's somebody who, because most of the time by 70, we have enough wear in more areas of the knee. So it's probably not the best option anyway. But if it is an option, I'll have that conversation with them. Say, you're a candidate for it if you wanted to. These are the pluses and minuses. Any other questions? All right. Well, thanks for sitting and listening to me drone. Hopefully you guys got some information with it. You're staying awake, so I didn't even have to go into some sort of